welcome, Dr. Janek. Thank you so much for taking the time to talk with the Texas Medical Association and Texas Medicine Magazine. We really appreciate it. As the new commissioner of the Health and Human Services Commission, you've been in this position a couple months now. You are serving a broad audience. I'm wondering if you could start out and just take a moment to address physicians who are, I think, interested to hear from you as a peer, and probably delighted to have a peer in a position like yours, about how you plan to work with and work for doctors in carrying out your agency's goals.
Well, first, it's important for everybody to understand this agency covers a lot of territory. Everyone always thinks about Medicaid and CHIP because that's the funding mechanism. That's the big piece of money that this agency is in charge of, and it's considerable. I mean, our budget request for the next biennium is about $77 billion in all funds. About $62 billion of that is Medicaid and CHIP. So it's a lot of money. We have 55,000 employees, but we cover things like regulation of nursing homes, assisted living centers, state-supported living centers to make sure that you've got adequate staff in the state-supported living centers, what we used to call state schools. So regulation of hospitals, child protective services, adult protective services, regulation and licensure of child care facilities, all the way over to CHIP, Medicaid, and the usual things that we think of. So a lot of that needs some clinical input from maybe a physician at the helm, but so much of this agency is directed by the staff and employees who know their subject matter and do a terrific job of this as a career. It's what they do every day. They get up and go to work, and they make sure that Texans are safe and food's inspected and kitchens are inspected at diners, you know, that sort of thing. So it's a very big agency. As for my colleagues in the medical profession, I think a lot of docs are excited that there's a physician running the Health and Human Services Commission. I'm not the first, by the way. Dr. Mike McKinney had this job at one point. It is a big piece of what Texas physicians do, from not their licensure, but licensing the facilities in which they practice, hospitals primarily, but also the funding mechanism of Medicaid. And our job is to do the most we can with the dollars that the legislature gives us within compliance with state law.
Is there anything you are thinking of doing to incorporate physicians and solicit some of that input in getting your agency on track and keeping things running smoothly? Has that crossed your mind?
It has crossed my mind, and it's apparently crossed the mind of a great number of physicians who already have my cell phone number. I get a fair number of calls with great ideas, and I mean that, some very good ideas. The input is coming in unsolicited, but in a more formal sense, it's important that the agency work with groups like the Texas Medical Association. The providers of the state, physicians at TMA are a big part of what we do. It's important that we keep them happy. I worry that, I know the statistics, fewer docs are now accepting new Medicaid patients. Their professionalism dictates that they continue, and I applaud this. They will continue to take care of the Medicaid patients that they've got, but they're leery about taking on new ones with the threats of lower pay, more regulation, that sort of thing. I would love to see us create a system of excellence and quality, better reimbursement to the providers of all stripes, not just physicians, that encourages those providers to knock on the door and say, hey, I want in, let me back in. This looks like it's good care, decently compensated, and I want to be a provider. If we can turn that corner and I don't get anything else done around here, I'd be very happy.
Let's talk about the budget a little bit. The budget crunch last session led to a lot of program cuts. We'll talk about some of them shortly. Where does HHSC's budget stand now? And I'm wondering if you could explain the I think as it stands, $4.8 billion shortfall from the last biennium and what we're walking into the next biennium. Where do things stand with that right now?
Last session was a little bit of an anomaly. Faced with uncertain budget future, lawmakers made the determination, using their best estimates as to Medicaid caseload and all the considerations that go into providing a budget for this agency. The lawmakers made a decision not to fund the very back end of the budget. It was a deliberate, thought-out decision, recognizing that they could come back and if situation dictated, they could tap into other funds. Maybe it was a rainy day fund, maybe it's a better budget outlook. And so to go to your question, we will enter the legislative session with about a $4.7 billion budget shortfall. It may inch up closer to 4.8. Okay. And much of that is just due to straight old Medicaid caseload growth. Some of it is an increase in costs, more patients utilizing more drugs and needing more hospital stays, for example. And some of this budget shortfall will be for that back end of the budget that needed to be funded. We'll do an emergency appropriation at the start of the session. We'll ask the lawmakers to give us the $4.7 billion, and that will keep the entire enterprise, Health and Human Services Commission, from running out of money literally in March. Okay. Early April under the best scenario, but probably more like March we would run out of money if we don't get an emergency appropriation. And
there was an $11.3 billion, I believe, figure you were quoted the other day. Could you explain that or correct that or whatever? Right. It gets yeah, we want to understand.
It gets fairly complicated. I'm at the point of our cycle where I'm thinking about a consolidated budget, and by that I mean looking at where we are now and adding in where we will be with the next biennium. So the fiscal year 2014 and 2015 budget. Okay, we're now in fiscal year 2013, which will run till the end of the summer next year. And so when I was asked a question, I was sort of looking at the global budget. So let me go back over that. We've got $4.7 billion for this budget shortfall. Okay, anticipating that same $4.7 billion would need to be there for the existing Medicaid caseload in the next biennium. All right, so that takes you to 9.4. If you add into that about $1 billion for caseload growth over at Department of Aging and Disability Services, an unfavorable Medicaid match, which is going to cost the state about $600 million. You start to add all these things up, and I was sort of winging it when I answered that question. It'll probably end up being for this current biennium, 12 and 13. The next budget the legislature will consider, 14 and 15, you add all that up, and it's probably about $12.5 billion over where we are from the previous budget that was passed.
Great.
That makes sense?
Sure does. Thank you very much.
It can get complicated when you start talking across years, and so I answered a question. Instead of just answering the question, $4.7 billion, I kept talking. Yeah. Which is always a mistake, right? Yeah, and I was talking in terms of a consolidated budget, so 12, 13, 14, 15.
Right. And I think that was the suspicion or general understanding, but I just kind of want to make it clear where
people like to know the numbers, and so I've asked my staff that when we go talk to the lawmakers, we come with the worst case scenario. I don't want to. We're not going to exaggerate, but I want to estimate on the high end, the more expensive end, rather than come say, you know, it's 4.7. Oh, by the way, it's 4.9. Oh, by the way, it's 5.2. We want the number to be as close to accurate as we can get. In instances where we have to estimate, I want to estimate high so that that's the worst case scenario that we present to the lawmakers.
You had already alluded to this, but I'm sure you're familiar with the statistic. According to recent TMA surveys, only about 1/3 of doctors are accepting new Medicaid patients now for a number of reasons. Payments is one of them. They'll cite, you know, administrative and bureaucratic type hassles. Managed care is now on the scene, some inconsistencies there, perhaps a layer with some of these fraud rules. Does HHSC in some way share any responsibility for ameliorating that statistic? And what can you do to make that number better?
Turning it around is not going to be easy. The number was drifting down. It's been a long time coming. It's primarily related to rates, but there is a hassle factor involved with becoming a Medicaid provider, opening up claims when questioned by the state and that sort of thing. To turn that ship around it's going to take some time. Honestly, it's going to take some money. Mostly it's going to take spending the money we have wisely, and that would include things like not getting pulled into spending money on things that end up being fraudulent further down the road. So it's hard to talk about keeping providers happy without talking about spending money in areas that simply overuse, abuse, or outright fraud. And so we're making an effort on all these fronts. We look at rates to providers of all stripes, as I said, constantly. Periodically, on a set schedule, we look and revise those rates as we think it's warranted. Again, I want to create a system where excellent providers of quality, are able to come into the system, and that's going to incentivize other docs to say, gosh, I want to be in there. I want my statistics to allow me to be part of that system.
Mm-hmm. Is there anything on the internal administrative side? And I know you've been here a few months, but what have you seen that could use some improvement? Do you have some examples on that front? Or
there again, for certain things, we're revisiting rates right now. We got to look at that balance. Rates, at some point, this quits being about what keeps doctors in the system and keeps doctors engaged with Medicaid and starts to be an issue of access.
Yes.
You can only winnow down so far, then suddenly Medicaid patients have a difficult time accessing care that they need. And so we continuously look at, administratively, look at where our docs are, where the patient populations are. On the fraud and abuse side, we constantly monitor those numbers. I know your viewers and your readers are going to be familiar with the orthodontia problem that we've had. We had a lot of orthodontic care was given, and yet when you go back to look at certain claims, if you look and somebody seems to be an outlier, they have an unusually high number of claims in absolute number and in dollar amount. You go back and look at some of those providers and say, we want to see the moldings, we want to see the little statue that's made of the child's teeth before you started, and they can't produce them. That sends up all sorts of flares as to, was this care really necessary? It's a very precise scoring system with orthodontia that the providers are supposed to hit. And it's one thing to say, I scored this kid's dental care as X, but then not be able to show us later on how they came to that score. It's very disconcerting. And we're not talking about a few $1 million. Hundreds of millions of dollars have already been identified where the providers just simply can't show that the care was necessary. And just because the state paid doesn't mean that they were free to go in and take liberty with unnecessary care. You can't do that. That erodes the public confidence in the system, and those dollars that are wasted on unnecessary care are dollars that we then don't have available for those providers who are doing the right thing. We're looking at medical transportation. I'd like to see a system where every visit, because Medicaid pays for transportation for Medicaid clients, whether it's a bus token or a cab ride, Medicaid pays to get to them to their doctor's appointment. But yet we never match up that payment to see whether there was in fact a doctor's appointment on the back end. In some cases, we'll pay families who will take their family member to a doctor's appointment. Well, it's only right for the taxpayers to fully know that that cab ride had a doctor's appointment on the back end, and right now we're not matching those up. We're looking at therapy providers all over the state, physical therapy, speech therapy, occupational therapy. There's a lot of dollars being spent, particularly in certain areas of the state that are just so out of line with the dollars in other parts of the state for therapy, that it's forcing us to take a look, saying, is it just like a blank check, or people just going for therapy without necessarily really needing it? So those are the kinds of things we look at.
Okay. I'm going to stay on fraud for just a minute. I was going to get to it later, but let's just jump in right now. I don't think there's a question that there are abuses, and it's well within your realm to go after that in this manner. I think the concern with physicians about these rules is that they may make legitimate unintentional type of errors a target for prosecution. Are doctors rightly concerned that this is maybe a backwards approach, a guilty until innocent proven approach with these rules? Why not spell out the difference between what's an error, not fraud, and what is? Could you address that?
Sure, let's do. To begin with, there's only a couple of ways you can sort of prevent fraud and abuse from occurring. Number one is that you could look at every claim as it's proposed before the care is delivered. In other words, prior authorization, which docs don't like. And I get that, I understand that. Patient needs the care, let's give the care, we'll sort the rest of it out later. And so let's just say that without doing everything as a prior authorization, that now we've gone to a system that says we'll assume the care is appropriate, we just want to watch as we go along. Where you get into trouble is that right now the Medicaid system is built to where it looks later, much later, a year, 2 years, 3 years later, and then looks at outliers and says, oh my gosh, this looks like it was being abused. Let's go back and talk to the providers. Now we're making them pull up records from the past, and maybe it was a harmless billing error, an unintentional, I should say, billing error, but they'd never found out any differently. You're not supposed to bill this way for this procedure, and yet they continue to do it over and over and over and over and over for 18 months or 2 years. Now the state is faced with, do we go back to that provider and say, it's not appropriate, yes, we were paying it in good faith, now that we've looked at it after the fact, we want to recoup some of those funds. Those funds may have already been spent. I mean, it becomes very difficult to go too far down the line. Here's an alternative to all that. One thing we can do is to look and monitor payments as they go through the system. And if you start to see an outlier using sophisticated software techniques, if you start to see an outlier, then you can call it to the doc's attention early on before it becomes a $100,000 error. Catch it when it's a $200 error and go to the provider and say, we noticed that you bill things this particular way, or that you perform surgery this particular way, and that every time, I'll give you a quick example as an anesthesiologist, if Medicaid looked up and saw that every time I did an anesthetic for a certain surgical procedure, I put in a central line, every time. They could come back later and make a big fuss about it, the way I billed or the fact that I put the central line in. Or you could look early and Medicaid could come to me and say, we noticed that you put a central line in for almost all your surgical anesthetic procedures. Why is that? And there may be a legitimate clinical reason. Maybe it's the hospital where I practice, or maybe it's the kinds of cases that I do, but there may be a legitimate clinical reason for that. And if I can show them that legitimate clinical reason early on, no harm, no foul. They say, we understand now. If I can't, it's better to catch that when it's a less expensive error to the taxpayers than to wait 18 months to 2 years. So we want to monitor payments as they go along. And it is possible now using sophisticated software techniques to pick up on the small error that over time can be a big error. More importantly, those same software programs can let you look at certain things that clearly identify overuse and outright fraud. And that's where you get into the real trouble. So I want the docs to know as we develop this, it is not about catching those small errors and prosecuting them. It's about correcting small errors before they become big dollar amounts. But it's also about watching for outright fraud and abuse. And most docs, gosh, every doc I talk to says, yes, we understand. If you don't pay $1 for fraudulent claims, it's $1 that's available for legitimate patient care.
And is that a scenario, because I think part of the concern is an investigation starts and payments stop while everything is sorted out behind the scenes. Do you see that as a situation that could avoid that scenario where you catch something early enough that there's communication and we avoid that? I don't know if you can speak to that, but that's part of the concern. If it's really not fraud, I mean, doctors have to go on and do their work.
It's a look. It's not necessarily fraud, it's a look. And so we have, for those instances where there's so-called a CAF, a credible allegation of fraud, the process would be this. If there is a credible allegation of fraud, and the lawyers over at the Inspector General's office look at this as basically the equivalent of enough credibility that it would justify a search warrant in front of a judge. So you have enough credibility to whatever this claim is that a judge would likely sign a warrant and say, okay, go search a home, for example. So with that credible allegation of fraud, we have the ability to put provider payments on hold, and that means that they would continue to accumulate. You investigate that allegation, and then you say, we found there's nothing, we'll release the money. And the important thing there for the docs is this should not drag out for 2 months or 3 months while they're waiting for payment. They've got cash flow needs to make to keep the office going. We're asking for more attorneys in the Office of Inspector General. I can almost hear the gasp amongst your readers and your listeners, your viewers. I understand that. It's that they will have to have something to do, and they'll go out and find allegations of fraud and the like. The purpose of these extra employees is to cut that time down. The Director of Enforcement, Jack Stick, former member of the House of Representatives, is a good attorney. I think Jack would be the first to say that he'd like to see about a 4-week processing time from the time an allegation is made, even if a CAF hold is placed, that we get this all resolved in a 4-week period of time. And what hurts the docs is when you start making this 8 weeks and 10 weeks where they're not getting paid.
Okay. I have one last question on fraud, we'll move on, but there's, I think you sense it, a little bit of a fear out there amongst physicians about how these rules are going to play out. What do you do to alleviate that, given you've got goals of increasing your Medicaid rolls and participation? You don't want this to be something to work against that. How do you balance those two forces? What assurances can you give? What can you do to?
Yeah, we've actually got a powerful ally, and that powerful ally is the doctors themselves. It has been my experience that when people from outside the profession want to come tell doctors, can't do this, have to do that, all sorts of defense walls go up, right? And yet, when you go into a morbidity and mortality conference, nobody's tougher on other docs and looking hard at the care that was delivered and questioning everything that took place than other docs. And so I want there to be a good, strong dialogue with TMA and other physicians as we go forward to say, how would you handle it? Surely you don't want us to spend money on claims that are fraudulent. Surely you don't want us to let a practitioner go out for 2 and 3 years and then have to come back later and recoup some of that money because they were billing inappropriately. Help us work out a system that works. If we do that, I'm convinced that in dialogue with the providers of all stripes again, but primarily it's about the physicians and the dentists and the Medicaid program, help us develop that system that works without forcing you to either quit taking new Medicaid patients or shutting down your practice. I think we can do that. It just, you got to keep talking to the docs.
Great. I'm going to go back to some of the payment issues. Again, we talked about the statistic, low physician participation in Medicaid. Your recent legislative appropriations request proposed included a 1% across-the-board cut in Medicaid and CHIP payments to physician and others. How do you justify that in the face of some of these low participation numbers? Where do you see that going? Not
to blame it on leadership, but we're given certain restraints. And those restraints are to keep the budget within certain parameters. They do say, when you're talking about Medicaid, adjust for caseloads, in other words, for more people, but not for more people more providers getting paid more, okay? So more people in the system, but don't adjust for provider rate increases. And then frequently the lawmakers will come back and say, if you had a 5% cut across all of your budget, how would you apportion that? And so typically we try to cut every single place that we can, but when you get back down to it, at some point you make provider cuts. It doesn't mean that's the end game. And most of those because we've now gone to a system of managed care throughout the state, it means that what's left is on the direct fee-for-service. And some folks say, estimates are around this building, that will always be somewhere between 10 and 25% of the caseload in Medicaid is fee-for-service, although that's not necessarily the case. So of those that continue to be fee-for-service, we may have to institute some rate cuts there. I hope we don't get there. I think we can do it without it. And again, that's the wrong direction. If we have to get to that point, I want to go back and sort of create the model for Medicaid, even in managed care, especially in managed care, that encourages docs to get into the system. Nobody will want to be in that system if they're both taking the risk and not sharing in the reward. The model that we hope to discover, create, stumble upon, I don't care how we get there, is to have that system where the providers are at the table saying, sure, we'll share in some of the risk, but we want some of the reward. So pay more when the quality is good, right? We can do more with less in certain areas, but we need to be able to do more with more in other areas. So you've got to have the providers at the table willing to take both the risk and to share in the reward. As I said, doctors can be tough on themselves and on their colleagues when the doors are closed and when it's not other people saying you have to do this or you can't do the other thing.
Are you talking about something like an accountable care organization type of model?
The model, I will almost promise you that the model is not out there yet.
Okay.
Maybe it is. Maybe it's an ACO. Maybe it's what we used to call an IPA. It's easy to get lost in the jargon. We joke that ACOs are sort of like unicorns. Everybody knows what they look like and nobody's seen one. At its most elemental form, it is providers saying we can do, based on our knowledge, our education and training, we know where we can do less, but we also know where the line is and what we have to have. I'll give you an example. Before I was offered this job, I became the chief of staff and the director of anesthesia services for a brand new hospital. And 1 year ago, about this time, hospital came to me and said, it's time to get us a capital budget. What do you need? I looked hard at what my choices were for anesthesia machines, which can be very, very expensive. And the very expensive ones are very nice. I don't necessarily have to have the $90,000 anesthesia machine if I can deliver good, safe, quality anesthesia with a $35,000 machine. And that's what I did. I suddenly had, by giving that option, saying, here's your budget, I knew that I could do more in our practice by spending less on the anesthesia machines, but still getting good quality, good dependable equipment, and knowing that that would free up some budget in other areas. That is a whole different scenario than the hospital saying, here's how much you get for anesthesia machines, let's move on. Here's how much you get for IVs and endotracheal tubes, right? It is a question of me getting serious and saying, they don't know what I know, and so my goal here is to decide where some cuts are appropriate and where they're not. And so whether it's an ACO or an IPA or some new alphabet soup that hasn't been invented yet, we got to get docs back in the game, willing to share the risks, but also participating in the rewards.
There's obviously a lot of focus on the payment side and that aspect of things for obvious reasons. It's a finite resource. But as a physician, you know that patient responsibility is a factor in this too, that impacts costs and outcomes, and it's one of those that is often out of the doctor's control. I'm wondering if there's anything that HHSC is doing on the patient side to incentivize patient responsibility, get them in the game too.
Yeah, we do that somewhat. with the Children's Health Insurance Program, CHIP. We've done that since its inception. I was a member of the legislature when we created CHIP with the federal government. There's only so much that we can do. Most of the time this comes down to financial incentives. It comes down to a copay, a premium share of some sort. The federal government gives you very little latitude to do that. On some populations, it won't let you do it at all. Even when it lets you allow copays, premium shares, and the like, it still is very clear and known by the patients themselves that even if they don't pay, you still have to take care of them. And there's the rub. So the question is, how far is society ready to go with this thing? It could be that the incentive out there is not so much financial. Maybe the incentive out there is do more for yourself, participate in wellness programs, for example, stop smoking, lose weight, all those usual sort of things that we doctors like to harangue people about. And we'll make sure that you get better latitude in clinic hours, for example, easier access to clinics rather than long waits in emergency rooms. If we can find that right mix, and I'm not saying that's the one, but we've got to find some sort of incentive, financial or otherwise, to get patients to get back in the game. Just like the docs want to be available for the rewards and they'll take the risks, we have to get patients back in the game to take control of more of their well-being, their health.
Let's talk about the Women's Health Program. I don't know if this is an accurate assessment. There seems to be maybe a little confusion about whether the quote-unquote new Women's Health Program has truly launched. Maybe it was a soft launch. I'm not really sure. Things are obviously in flux with the courts. I understand that. Could you tell us what the status of that program is now? Is there something different between what's happening now, what January 1 could bring? What's the status of that now?
Sure, and if you don't mind, I'll just take a few minutes, a couple of minutes here to kind of go through the history. 5 years ago, the state of Texas applied for and received permission from the federal government to operate a women's health program, waiver. And what that means when you go for a waiver, you're telling the federal government there's a certain population we want to take care of. We're not going to give them all services for all things. However, certain limited numbers of services or scope of benefits we want to provide to a certain population that otherwise would not be eligible for Medicaid. We'd like to do that. The federal government said yes, 5-year waiver. They gave us the waiver, and Texas operated the Medicaid Women's Health Program under that waiver. The waiver was about to expire, but the last session of the legislature got a little bit tougher with a rule, a state law that had already been on the books, and it said that state money will not go to abortion providers or their affiliates. And the affiliate question is where the rub comes. HHSC had never defined affiliates. We were directed by the legislature to do that, define affiliates, and then stick to it. Medicaid money, state dollars, will not go to abortion providers or their affiliates. And so what had sort of been the norm for groups like Planned Parenthood is the complaint was, well, at 2 o'clock the sign flips and they quit being an abortion provider, now they're a women's health program. And they'll set up a corporate distinction from one to the other, but it's really the same thing. That's where the legislative rub came, and that's where the lawmakers got involved. So we set up, created some rules, including the affiliate rule, defining what an affiliate is and certain contractual obligations that are met and that sort of thing. We set that program up and told the feds we'd like to do this, and they said, can't do it. You cannot exclude one group of providers, and so if you do that, you will not be eligible for Medicaid matching funds. And that's when Texas said, great, we'll go it alone and fund this. We want to participate as a Medicaid program, but if we're forced out, we'll operate this as a straight general revenue without federal funding. We put the program together, but the state has always had an eye on continuing it as a Medicaid program with the exclusion of those abortion providers and their affiliates. And this is where the federal law and the state law both come to bear. My job as the agency director is to comply with both. And if both are not clear, one conflicts with the other, everyone runs to the courts. HHSC filed in federal court ask a federal court whether we have the right to create a Medicaid women's health program that does include certain providers. Some of those providers went to state court and federal court. Injunctions start flying back and forth. At the end of the day, my job is to make sure that we've got a system, whether it's Texas Women's Health Program or our Medicaid Women's Health Program, that provides the care, basic primary and preventive care, including family planning, to the 115, 120, some estimates 130,000 women, low-income women in Texas who need it. That's my job. I will do this as long as we can do it as a Medicaid program. If it's not allowed by law, and we'll let the courts figure that out, and CMS, then I will do it as a state-funded only program. Either way, I can do it, but we won't know the answer to that until all these court cases come to some resolution. My job is not to decide if this is a good and righteous thing or not. My job is to get it done and to make sure that these low-income women have access to these very important services.
And talk about what you've done to prepare for that. What are you doing to get physicians enrolled, clinics enrolled, signed up, have enough of them, and if you could speak to the difference between, I'm sure you know, there's a difference between a 1 or 2 doc practice that can take a handful of patients and some of these clinics that will no longer be in the program that we're taking hundreds. How are you prepared to go forward with this? Where do things stand right now with that?
We started with the existing Medicaid providers and with outreach through TMHP, Texas Medicaid Healthcare Partnership, one of our claims administrator, and started making phone calls to the existing providers and said, we're creating this new program if we need it. We'd like you to be a provider if you certify. Last spring we certified a lot of them. We now have a certification process set up now that our rules are finalized. We have a certification process set up. We want this to be easy for the docs. We want it to be seamless for the patients as they transition from the old Medicaid program to the new TWHP, if that becomes necessary by court ruling, or if they transition from simple Medicaid eligible, if they're pregnant, after 30 days after delivery, they transition over to the Medicaid Women's Health Program. We want it to be seamless. We want it to be easy for the patients. We don't want them caught in the middle of this conflict. We're confident we have enough doctors. We went out and found 3,000 doctors. Many of those doctors said it was always another big provider who's no longer allowed, Planned Parenthood, and I'm not trying to diminish them, but that's basically who we're talking about. Got most of that business. That was a practice model that they had built around, and they were very efficient at it. And so now that there's that opportunity to take care of these patients, I'll do it. We're now in the process of gauging the capacity, the issue you went to, which is, okay, you're 4 docs in a group practice. How many patients can you take? And we'll start to, we're calling them again and trying to figure out exactly what our capacity is. But we know our geography is good. We've got a good spread of the docs all over the place. And we're going to make sure that our capacity is good. Well, we got a bit of a bum rap. Some of it was self-inflicted because we had a provider list, not our official database, but a provider list that had not been well filtered. So you may have 1 doc with 3 different office locations. Well, that's not 3 different providers. And yet if you went through and you saw those 3 different locations, you would think that we had counted them 3 times. Our number of 3,000 is predicated on a provider, not at 3 different locations, a provider, and that's where we get the 3,000 number.
The dual eligible payment cuts were a big hit to some doctors, particularly in certain regions. I think you know that. Will you advocate to restore those cuts?
We're working hard on that. This was part of the budget cuts of last session. There was 2 things. Number one, there was the not paying the copays as Medicaid has historically done, the Medicare copay for the dual eligible, and the other was the deductible. Did I say that right? Not paying the deductible and also a reduction in the copay. These are big hits to certain providers in certain regions of the state where it's most heavily concentrated. in an attempt to sort of restore some of that, you've got to figure out how much money you can get to go do that, where it's going to come from and other parts of the budget. And then you have to say, first question to ask is, are we going to restore that for all providers, even if it was not a big part of their practice in a region of the state that doesn't have a lot of the dual eligibles, or can we do it for everybody? Well, number one, to go on try and say we'll do it for some docs but not others is very problematic. Even if the docs you don't do it for don't pitch a big fuss, it is extremely problematic to say to which doc is this a big portion of their practice. If 3% of their practice is dual eligibles, they may not care, but we don't know it's 3% unless they let us in and look at their books. We're not about to go look at the books of every practitioner in the state who's a Medicaid provider. And so you have to decide, okay, if you restore some of that for one, you have to restore it for all. Right now, our best hope is, pardon me, our best hope is that we can restore some of those cuts on the deductible side. We think that's the best place to look right now, and that's what we're exploring. I don't know that we're going to get this done. It requires the cooperation of the legislature because it is money. It is money that would otherwise be available for other things. So we're trying to get that done. We do have a couple of bright spots on the horizon. Many of these docs are also primary care providers. And because of the Affordable Care Act, one of the bright spots in the ACA was that there are provisions of straight 100% federal dollars coming for primary care docs. And we're working to determine what that number is going to be, what the conditions of it are. But primary care docs should see an increase. Certain primary care docs will see an increase in their Medicaid reimbursement paid for with federal dollars. That's supposed to become effective January 1. I see nothing right now that tells me it won't. But we're working hard with the feds to make sure those dollars are available.
Would you consider looking at expanding? I think there's a particular definition of primary care docs under that ACA provision you're talking about. It's family doctors, pediatricians, internists. Would you consider expanding that to other primary care doctors, OBGYNs, the subspecialists they work with to kind of get more mileage out of that?
To the extent, yes.
Is that a possibility?
To the extent that the CMS and federal law allows us to do that, we're constantly looking at those things. We get updates regularly from CMS, and to the extent that we're allowed to do some of that, particularly when it's 100% federal dollars, we're happy to do that, sure.
Speaking of health reform, the recent census numbers still put Texas at the top of the list, which normally would be good, but not really good in this situation in terms of the number of uninsured. Still about a quarter of people here are uninsured. There's some divisions in the state about Medicaid expansion. What's your view on that, on whether we go that route? You've been a proponent of waiver flexibility. Is that something that could make it more feasible? Can you give us some thoughts on that?
Sure. First and foremost, this is a decision for the policymakers. I serve at the pleasure of the governor of Texas, and I agree with the governor. It sounds enticing to take that federal money, but are you going to have to spend money later once you've entered into that system? What's that cost going to be, and is the system broken? I think everyone, including the providers, your viewers, the readers of Texas Medicine, would agree that the Medicaid system is broken. And to go further down out on that limb for the short-term effect of some 100% federal dollars can put the state in a big dire straits later on. So my job is to find out how we can do more with the resources we're given. I think rather than provide all services to all people in Medicaid, I'd like to see a system that gave us more flexibility, not necessarily by waiver, but sometimes by change in federal law may be required to allow us more flexibility to design a system that works for Texas. Quick example, a broken arm for somebody who barely makes the income qualification for Medicaid is a bad thing. It's a broken arm, and that's unfortunate. But consider that person who now falls outside the limits of Medicaid, falls outside the limits of Medicaid expansion. What about that person who gets a serious illness and suddenly you could bankrupt their family? Medical bankruptcy is not that common, but it's frequent enough that it should cause concern for everybody, including me. And so I'd much rather see a system that says we may not cover everything for all people, but certainly for those at the lower end of the income scale, we're not going to let you go bankrupt because somebody in the family gets cancer. We're not going to go there. And so I think we can design a system that fits Texas in a much better way, including utilizing our medical schools and the brilliant minds that we have, the outreach of the medical schools. They're centered in those population centers: Houston, Galveston, Dallas, Fort Worth, Lubbock, San Antonio. That's where the population centers are for Medicaid. And to the extent that we can leverage better Medicaid funding for the medical schools and ask them to take care of that Medicaid population, now you've taken that $1 of straight medical school funding with no match, $1 with no match, and turned that into $2.47, let's say. So there's constantly challenges in this job.
My last question. The state has gone ahead with expanding Medicaid managed care. And I think doctors want to hear from you a little bit about what HHSC is doing to hold those health plans accountable for things like network adequacy, high quality, making sure some of the hard to manage populations like the dual eligibles are taken care of. What are you doing to hold them accountable? We
are constantly revisiting the contracts. As we build those contracts with the managed care organizations, we like to think that we're one contract amendment ahead of them. Sometimes maybe we're one contract amendment behind, but we get more sophisticated all the time in how we build those contracts. We want to look at things, not whether it takes 90 seconds or 120 seconds for the phone to be answered. That's neither here nor there. How are the services provided? How quickly are providers paid? There's a lot of things that we get better all the time at building into those contracts and then holding them accountable. Recently, we had one health plan that participated in Medicaid that suddenly just cut rates precipitously. That caused a lot of the recipients of Medicaid services to then leave that plan and go to other plans, and it turns out they were some of the high-cost recipients of services. So they improved their bottom line to the expense of the other health plans in that area, and we have the tools called liquidated damages in our contracts with the managed care organizations so that we can go back to those plans and say, you didn't meet the contract requirements, you didn't negotiate in good faith, whatever it was, and we're going to recoup some money from you. There will be a financial penalty under liquidated damages to get some money back if you didn't meet the terms of the contract.
Doctor, it was a pleasure speaking with you. Thank you so much for addressing our membership and gave me some ideas for follow-up stories too. So I'll talk to you again. Thank you.